All right, class, welcome to Introduction to Radiation Protection and Biology. X-rays was discovered in 1895 by William Röntgen. The ability of X-rays to cause injury soon became apparent. Do you remember how X-rays were produced at the anode at the target? So if you remember back in Dawes' class and Francis's equipment class, you set the technique on the tube. That would be your KVP, your kilovoltage peak. You heat up the filament to produce a space charge. You accelerate the electrons from cathode to anode. You stop the projectile electrons abruptly or slow them down at the target. Conversion of electrons, the kinetic energy of heat and X-rays. So basically it's 99.8% heat and 0.2% X-rays. Bremsstrahlung and characteristic properties are at the target. The most important thing to know here is that KVP is what you select on the control panel, and what comes out is actually called kilovoltage electron, KEVs. So you have KVPs on the control panel and KEVs, kilovoltage electronic voltage, that comes out of the X-ray tube, and that's what strikes the patient. What comes and strikes the patient is called the primary X-ray. So what you also need to know here on this image is that there can be leakage from the glass tubing. There's different ways to keep the radiation from coming out, and the glass tubing, the glass housing is one of the ways that kind of filters the X-ray beam to come out where the little target window is right there, pictured right over here. All right, so let's go to the next slide. Electromagnetic spectrum. So basically there are many different things on the electromagnetic spectrum. You have gamma rays, which is the strongest ones, X-rays. Ultraviolet rays can actually be considered cancerous or non-cancerous, just depending on how strong the wavelengths are. So there's visible light here, infrared, microwaves, radio. This is all part of the electronic magnetic spectrum. The shorter the wavelength, the higher frequency, the higher energy, means that it's going to be more of an intense energy. So in this case, the radio waves, the microwaves, the infrared waves, so like AM radio, FM radio, microwaves, infrared, have a longer wavelength, lower frequency, lower energy. The electromagnetic spectrum showcases the range of frequencies and wavelengths. So for this lecture, we will divide the electromagnetic spectrum into two categories: ionizing radiation and non-ionizing radiation. So the non-ionizing radiation is going to be the infrared, the microwave, the radio. The ionizing radiation is some parts of the ultraviolet, the X-ray, and definitely the gamma. For this, we're going to talk about how X-rays are, they have two properties. They also can act as a wave or as a particle. So the X-rays, they are particles, and then they travel in a form of wave. So they can go in a like a long wave right here, or they can do a short wave like right here. Right. So ionizing radiation produces charged particles when passing through matter. They can be positive or negative. The charged particles are the problems. Why they can cause ionizations of atoms and formation of free radicals. So free radicals is what basically causes DNA damage in the body. So basically it's going to create negative ions or positive ions. Let's see. Ionizing radiation, this type of radiation produces positively and negatively charged particles. This production may cause injury in normal biologic tissue. Since we know the potential injury ionizing radiation may cause, we as X-ray techs employ effective methods to limit or eliminate those risks. Those radiations include X-rays, gammas, high energy ultraviolet radiation above 10 eV. So like I said before, KVP is what you select on the control panel. What actually comes out of the tube or what may affect our bodies is the electron volts. Consequences of ionization in human cells: creations of unstable atoms, production of free electrons, production of low energy X-ray photons, creation of reactive free radicals capable of producing substances poisonous to the cell. Again, the free radicals is what causes the DNA damage to our bodies. All right, so free radicals. Formation of free radicals comes from ionizing radiation, from smoking, from air pollution, inflammation, and we actually have it naturally occurring in our own metabolism. Again, there's that UV light. And so what that does is breaks up the DNA damage right here. So we're talking about like double strand breaks, point lesions. We'll talk about that in later lectures. Non-ionizing radiation. The following are termed non-ionizing radiation. Low energy ultraviolet radiation, visible light, infrared rays, microwaves, radio waves are non-ionizing. They don't have sufficient kinetic energy to eject electrons from the atom. So kinetic basically just means movement. So it doesn't have enough movement energy to elect electrons from an outer shell or an inner shell or from the nucleus itself. Again, here's the electromagnetic spectrum. You have UV light, infrared light, radio light, microwave. So this is the same as the other diagram that I just showed you earlier, but it's important to know why. So low energy, low frequency, longer wavelength. So these are going to be your weaker energies. These are going to be your higher energies, higher energy, higher frequency, shorter wavelength. So this is going to interact more with the tissue. Radiation, energy in transit from one location to another, can be a mechanical vibration, ultrasound, electromagnetic wave, RF, microwaves, X-rays, visible light. Particulate radiation is a form of ionizing radiation causing ionization when moving, not at rest. Are particles rather than waves, varying ability to penetrate and travel, alpha, beta, neutrons, fast neutrons, and protons. So we don't deal with alpha, beta, neutrons, or protons in diagnostic X-ray. So what we do at clinic, we're not really involved with any of these other things. If you're doing radiation therapy, nuclear medicine, then you're going to be dealing with like alpha particles, beta particles. Fast neutrons, most likely that's like cyclotrons. Those are when we're actually creating the gamma seeds or whatever nuclear medicine uses. Particulate radiation is the characteristic of X-ray where it could be a particle or it acts as acts on a wave. So again, the X-ray is a particle, radiation is a particle, and then the way it travels in a wave in a straight line. Varying ability to penetrate matter. So depending if it is X-ray or if it's alpha or if it's beta, not everything can penetrate the same. So it's not only the KVP that's elected, but like alpha particles cannot penetrate the skin or like a piece of paper. Gamma can almost penetrate just about anything. The radiation that was used in the atomic bombs was the gamma radiation. So particulate radiation ejected from atoms at very high speeds can cause ionization by direct atomic collision. No ionization occurs when these particles are at rest. Alpha particles are radioactive decay. Like I said earlier, this has to do with like nuclear medicine. Beta particles capable of penetrating at a greater depth. So alpha particles, they cannot penetrate, but remember for nuclear medicine, they actually inject or they ingest those particles. So that's why it's dangerous once it's inhaled, injected, or injected, inhaled. All right. Which penetrates the most? Alpha particles cannot penetrate a sheet of paper. Beta particles cannot penetrate the plywood. Gamma rays get stopped by concrete. So the more ionizing, which means it moves around a lot, is less penetrating. Less ionizing gamma or X-ray is more penetrating. Why do you need to know this? Different particles have the ability to do damage. Different types of radiation have the ability to do damage. So it depends on if the different types and the particle's ability. So sources of radiation, there's two types. There's natural, which is made in the natural environment, and then there's man-made or artificial. Humans, we get radiation from man-made from traveling in airplanes. So as you travel, you actually get radiation from traveling in planes. Nuclear power plants And this is the breakdown of how much radiation we get. And as you can see here, CT, you get the most dosage here. Radiography, not so much. Nuclear medicine is less than CT. Okay, and then for the natural made, the terrestrial that's in the ground, internal is the free radicals that are made inside our bodies. Space is like cosmic, and radon and thoron is actually in the ground. And that's when we're going to talk about radium later on. Radon you can find in basements. So all of that totals to about 5.5 millisieverts. And we're going to need to know the unit of measurements in SI units. So millisieverts is what we need to know. This is the combination of natural and man-made sources. Natural radiation has always been a part of the human environment, results in an estimated average dose of 3.1 millisieverts, radon being the biggest contribution. So again, that's what you find in basements or below sea level. The ionizing radiation from environmental sources is called natural background radiation. 3 components: terrestrial, radioactive materials, and Earth's crust. Cosmic is from the sun. And internal is what happens in our body with metabolism. Terrestrial radiation: uranium deposits in Earth. Radon is a decay product of radium. 30% of gross common exposures is related to radon. Radon is found in the ground, concrete, bricks, and drywall. Thorium deposits in Earth. Radionuclides in ground. So man-made artificial radiation. Radiation is created by humans, contributes to about 2.5 millisieverts to average annual radiation exposure of the U.S. population. This includes consumer products that contain radioactive material, like makeup back, a while ago. They used to use radioactive material in that. Anytime you travel on a plane, you're getting radiation. Nuclear fuel for generation of power, atmospheric fallout from nuclear weapons testing, nuclear power plant accidents like Chernobyl, and of course medical radiation. So we're going to talk about the organizations that basically monitor and kind of protect us from radiation. This is called NCRP, the National Council of Radiation Protection. Their report number 93 in 1988, medical radiation estimated to contribute to 0.54 millisieverts. The National Council of Radiation Protection report number 184 was created in 2000 or published in 2019, reflects that medical radiation accounts for approximately 2.3 millisieverts of radiation. So it's gone up by a factor of 4 from 1988 to 2019, largely due to the use of CT. Simply put, the amount of energy transferred to electrons by ionizing radiation leads to calculation of equivalent dose. Equivalent dose is the radiation quantity used for radiation protection purposes. Effective dose accounts for all types of ionizing radiation to organs or tissues in the human body. The International System of Units SI identifies the sievert as the unit of radiation dose. We'll be discussing more of this in future chapters. The most important thing that you need to know is that the effective dose is one step more than the equivalent dose. The equivalent dose has to do with the type. So are we talking about alpha particles, beta particles, X-ray? That is the radiation quantity or the equivalent. So for instance, if I said that you're getting 1 sievert of X-ray or you're getting 1 sievert of gamma, there's a big difference because one is more deadlier than the other. The effective dose has to do with the specific tissues of the body or the organs. So the thyroid is actually less sensitive than the gonads. So equivalent dose, these are important terms you'll need to know. A quantity that attempts to take into account the variation in biologic harm that is produced by different types of radiation by considering the different type and energy of the radiation, measured in sieverts, or the old term is called REM. On your Landauer reports, it'll probably be listed as both sieverts and REM. Enables calculation of the effective dose. So this helps the radiation safety officer or or anyone basically calculate the dose that a person would get working in the field or as a patient. So like if you're a cancer patient, they want to know like how much radiation you're getting. The effective dose quantity used to provide a measure of the overall risk of exposure. So this looks at the equivalent dose and it basically adds in the tissue weighting factor. So somatic effects are effects to the body that you can visually see or feel. So somatic has to do, soma in Greek means the body, and genetic effects have to do with future generations. So what tissues are you rating or affecting? Also measured in sieverts or the old unit, or the ones that we use here in the U.S. is mostly the rem. So this is for occupational dose or non-occupational dose, because as X-ray techs, you get X-rays yourself whenever you go see the doctor for your annual checkup, or occupational dose is when you're X-raying other patients and you're getting dose from scatter. So then, equivalent dose looks at the type of radiation used. Effective dose looks at the type of tissue you're radiating. So effective dose, you also need the equivalent dose. Biologic damage potential. Biological damage can stem from ionizing radiation, result of ejection of electrons from atoms and body tissues. Cellular damage occurring at the atomic level can result in molecular change, somatic effects, genetic effects, mutations, cataracts, leukemia. We'll be discussing more of this in future lectures. So what does biologic damage potential mean to us? So will it affect our future generations? Will it affect hair loss? Will it give you cataracts in your eyes? Right. So radiation protection. Radiation protection, the definition is effective measures employed by radiation workers to safeguard patients, personnel, and the general public from unnecessary exposure to ionizing radiation. Risk of imaging procedures. In radiography, risk is the possibility of inducing radiogenic cancer or genetic defect after radiation. Medical imaging equipment and radiation safety standards have improved greatly, reducing risk from imaging procedures for both patients and radiographers. Patients who understand the benefit of imaging through proper education, information before the exam are more likely to overcome the radiation fear. So basically this says is that we're just trying to reduce the risk of irradiation for ourselves and for patients. We don't want to give anyone cancer. We don't want to create genetic effects. Genetic effects doesn't always occur in the next generation. It could happen 2 or 3 generations down. Benefit versus risk. There's always potential benefits, potential risk of biologic effects. Risk of radiation exposure for procedures does not outweigh the benefits achieved from the exposure. Some exposure is necessary to provide the information in order to make a diagnosis. So basically, for example, like when you have to x-ray a pregnant woman, a pregnant patient, is the benefits outweigh the risk. So in some cases, we have to x-ray a pregnant mother because if the mother is too sick, then the baby won't survive anyway. So we have to make sure if the mom has pneumonia or something going on, that we need to be able to save the life of the mother and then hopefully the life of the child as well. Diagnostic efficacy. Defined as degrees to which the diagnostic study accurately reveals the presence or absence of disease in the patient, sometimes just called accuracy. You've got it and we can prove it. Maximized when essential images are produced under recommended radiation protection guidelines. So basically what this says is that we have the correct patient, we're doing the correct exam, and we're making sure we're doing what's right for the patient, meaning are we collimating, are we talking to the doctors and asking, oh, do you really need all of these different exams, or why don't we just order these 2 exams? So instead of ordering a humerus, an elbow, and a shoulder, why don't we just order the shoulder and the elbow, and then that'll give us the humerus as well. So diagnostic efficacy is the imaging procedure or practice justified by referring the physician, the minimal radiation exposure, meaning knowing your techniques, producing the optimal images, presence or absence of disease is revealed, and that means that's why it's diagnostically efficacy, because we could prove that yes, this person has a disease, or we proved that okay, maybe it's not this, but Now we can go to the next step and order the CT or maybe order the MRI or something else. Radiologic technologists and physicians work hand in hand to ensure that patients receive the lowest radiation exposure possible. Occupational dose versus non-occupational dose. Occupational dose. Should you wear your monitoring badge? Where should you wear your badge for routine work? Where should you wear it for fluoro? What is different if I'm pregnant or if I'm a student? How do I determine my occupational dose? Non-occupational dose. Where do I wear my badge for this type of dosage? How do I track my non-occupational dose? What are some examples of unnecessary exposure? Improper technique, not shielding patients, not collimating primary beam, using large film when a small film will suffice, not verifying pregnancy appropriately, allowing unnecessary people in room during radiographic exposures, holding patient during exposures. So this is an example of how we usually take x-rays. This is how we're supposed to do it, and this is how sometimes we kind of just do it already. So whenever an instructor tells you that you need to collimate more because we know you turned off the override switch on the key, you think you need more light on the front end of the patient, but technically, even though the light is smaller here, everything should be on the image back here. That's why we have detectors in the machine that tells us exactly the size of the film that we're using. When we collimate, everything should be on the cassette, whatever's in the light field. All these images are results in repeat exposures, not the best practice for diagnostic efficacy. Because we should have taken the bra off here, we can see the underwire, we can see the snaps in the back. This patient still has a necklace on. This person has a cigarette lighter in the hip area. This was an older facility where there was a cassette that was used, and then they used the same cassette to take another image, and they actually repeated. They actually got two images on the same film, so basically they have to take They have to take two more pictures after this one. So the patient was exposed 3 different times. This one here, bad positioning, and the technique was off, or maybe they didn't use a grid because you can see the lines right here too. Okay. So ALARA, as low as reasonably achievable. It also means optimization for radiation protection. So basically they made the same thing. Sometimes you'll hear, most of the time you hear ALARA, but sometimes you may hear someone refer to as optimization. Critical rules for radiation protection. We've already learned this in prior classes. Time, distance, and shielding. So the most important thing that we can do is actually, reduce the time that we're exposed in there. The distance, every 6 feet it basically drops 1,000 feet. Yeah, every 6 feet it basically drops 1,000%. We can definitely wear shielding, but a lot of places for patients they're getting rid of the shielding and they're basically telling us to use more of our time and distance. For patient exposure, reduce amount of X-ray on time. So that means for mass, use more of the MA and less of the seconds. Use as much distance as possible when you can. Always shield patients when possible. So a lot of places, except for Herman and Texas Children's, they do want you to shield. So if you're at Methodist, they want you to shield. Most places, they will ask you to shield for anyone 50 and under. For occupational exposure, shorten length of time spent in a room, standing as far away from the X-ray beam as possible, and wearing shielding. So you can always wear your shields whenever possible. Whenever I work, I usually wear my apron all the time. Who's in charge of radiation safety? Everyone is responsible for radiation safety, but the person who's in charge is the RSO. So you need to know the difference between the two. Everyone is responsible, but the RSO is in charge. Usually, the RSO usually has a graduate degree in medical physics, health physics. They're responsible for maintaining radiation safety in a workplace setting. They identify radiation safety problems, initiate, recommend, or provide corrective action, stop unsafe operations involving byproduct material, and verify implementation of corrective actions. So we all know that Dr. Ho is our radiation safety officer here at school. Educating patients about imaging procedures. Patients should be educated about imaging procedures. what should a patient know before a procedure is done? So we want to know when, where, what, how, why, and these are all things that we've taught you in practicum, and this is what we look for when you're in clinic. Radiation. What are some potential questions a patient may ask you regarding exposure of their radiographic exam? Usually they ask you, am I going to glow after this test? How long does it take for the results to happen? Will this cause cancer? Are X-rays safe? Yes, sir. You only get 0.06 millisieverts of radiation for a chest X-ray. Is this an effective way to address the question? No, because we don't really understand how much 0.06 millisieverts is, and a patient definitely won't either. Is this an effective way to address the question? No. Any explanation where we give actual values to patients may be difficult for them to understand. The received dose of radiation can be measured in several different units. We'll talk about grays, we'll talk about sieverts, we'll talk about rads, we'll talk about rems, we'll talk about curies, becquerels. Scientific units for radiation is not comprehensible by the patient. So basically just use layman's terms or just use normal words. We aren't trying to provide high scientific accuracy, but we are trying to calm anxiety about radiation with an understandable and correct answer. BERT, background equivalent radiation time. This is a way radiographers can reduce anxiety and fear through a method that provides a little more clarity and understanding. This method does by comparing the amount of radiation received in comparison to the natural background radiation received over a period of time. This method is actually recommended by the NCRP, the National Council of Radiation Protection. So correct conversion utilizing BERT. How much radiation will I receive from this chest X-ray? The radiation you will receive is equal to what would be spending 10 days in your natural environment. BERT is based on the annual U.S. population exposures of approximately 3 millisieverts per year. BERT does not imply radiation risk. It is used just for comparison. BERT emphasized that radiation is an innate part of our environment. BERT is easy for patients to comprehend. It should not be used, we should not use the word BERT in the explanation. So this is the BERT of commonly performed exams. So dentist is basically 1 week of radiation in our natural environment. Chest X-ray is 10 days. C-spine is 2 weeks. T-spine is 6 months. Lumbar spine is 1 year. Upper GI is 1.5 years. Lower GI is 2 years. Skull is 11 days. Hip is 7 weeks. So just be careful when you're doing your spine X-rays or your abdomens, because it takes almost 2 years for to get the equivalent in the natural environment. Radiation safety of children. Children are more sensitive to radiation than adults are. So cases of cancer, this shows a lot more in kids than later stages of life. But we'll talk more about this in future chapters. So what are we doing to protect kids? So Alliance for Radiation Safety in Pediatric Imaging, founded in 2007, purpose to reduce the radiation dose for pediatric patients and raise awareness of detrimental exposure of children to radiation. Studies showed in 2007 many physicians unaware of the risk posed by CT to children. The Alliance put forth the need for dose reduction protocols when scanning pediatrics and decreased use of high radiation exposure, such as CT in pediatrics. Studies found from 2003 to 2010 there were decreased trends in CT use in favor of alternate modalities in pediatrics. So just like when there are campaigns for you to wear your seatbelt, so then there is a decrease in the loss of life when those campaigns are enforced, because the more people that are aware that they need to wear their seatbelts, then the incidences of fatalities decreases. So the same thing with this campaign, where the more we talk about the dangers of radiation, especially with children, then now people are more aware of it, and then they may not order as many CTs, or they may order alternates like ultrasound, or they'll do mainly more just X-rays, or they'll use pediatric doses on the CT machines than adult doses. So this was called Image Gently campaign. It's in January 2008, the Alliance launches the Image Gently campaign, which mainly focused around CT. This campaign aimed to spread information on pediatric dose reductions. Radiology departments or individual radiologic technologists can pledge to image gently. This pledge includes the following: make the image gently message a priority in staff communications each year, review the protocol recommendations, and when necessary, implement, adjust practice processes, communicate openly with parents. So what can we as radiographers do to image gently? So basically every year I go on this website and it gives me suggestions on what I can do to reduce doses for kids. One of the things is collimating and using high kVp, low mass. And then I basically sign this campaign every single year, and I submit this to my lead tech or supervisor, and then we keep these on file. And whenever the College of um, the ACR, the American College of Radiology comes by to accredit each facility, they look for these campaigns to see if the employees have done this or not. So Image Wisely is another campaign. Radiation safety and adult imaging. Image Wisely campaign formed by the American College of Radiology, which I just mentioned, and the Radiologic Society of North America to address concerns about the increase in public exposure to ionizing radiation from medical imaging. To address the need for lowering the amount of radiation used in imaging studies and eliminate unnecessary procedures, basically, again, are we repeating the scan? Do we really need this test done? Was this exam done at another facility just recently, and can we use it for comparison? What else? Yeah, that's about it for that one. Monitoring and reporting dose. More demanding reporting of patient dose is being seen. In CT and interventional radiology, patient dose recording is being the norm. Some states even require a log of skin dose for each patient be kept as part of the patient's record. The skin dose is where we get most of our radiation. So let's say someone wants to look at the lungs. Well, we have to go through the skin first. There's many layers of skin. And when we x-ray someone, the skin actually gets the most radiation, and then it finally penetrates to the organs that we want to see. So the most dosage, if we shot like 100 kV at someone, like all that 100 kV is going to hit the skin, and then when it finally gets to the lungs and the heart and the T-spine, then it might be only like 60 or 70 kV. Indications of dose reporting being a requirement for all modalities in radiology is being seen. Facilities often have alert levels. When patient's dose has exceeded a certain dose level, radiologist is notified. Sometimes even the medical physicist may be called. Are you seeing any dose reporting in clinic? So we've had students before in the past where they have gone over the dose limit because they were in surgery, and then our RSO has to step in and basically tell the student, okay, you need to stay out of surgery for a little while, or what do we, they ask the student, what are you doing that your dose is so high in surgery? So then we find out, oh, the student was standing too close to the C-arm. They didn't step 6 feet away, or they forgot their apron with the dosimeter in surgery, and it was just getting dosed when the student wasn't there. So we just had to figure out why the student is getting more dose. So showcase some organizations that aim to reduce the radiation exposure found in medical imaging. Guess what they did? The National Council of Radiation Protection report number 184, published in 2019, showcased that there was a reduction of medical radiation exposure by 15 to 20% over a 10-year period. Changes in technology as well as campaigns to increase dose awareness and reduce dose among the medical community and the public seem to be having the desired effect. And this is another reason why we're not shielding at Hermann and Texas Children's anymore, is because there's been a reduce in dosage.